This is the overview. I'm going to touch on all the different subtypes of breast cancer, and there were actually a couple of um, abstracts about cancer prevention. And I think that we sometimes don't talk about that or don't think about that enough in the medical oncology world because most of the patients that we see already have cancer. Um, but I thought that it was a couple really interesting topics. So here's what we're going to go through. I'll get into the details of them. I wanted to just, before we dove into the science of the studies and the results, I wanted to just give some definitions and terminology and kind of an overview of some of the terms that we're going to talk about. I did a little bit of this last year if you were on the same call, but just to summarize, so ER positive or HR positive, this is estrogen receptor or hormone receptor positive. Those are the cancers that are fed by estrogen and that we treat with endocrine therapy or ET hormone blockers, anti-estrogens. Those are all different terms that we might use in clinic. TNBC is an abbreviation that's short for triple negative breast cancer. This is where the ER, estrogen receptor, progesterone receptor, and HER2 are all negative. And on the next slide, I'm going to just show an illustration about what that looks like. The term adjuvant refers to giving treatment after surgery, and neoadjuvant means before surgery. So sometimes we give neoadjuvant chemotherapy before surgery. Sometimes we give adjuvant chemotherapy or adjuvant therapy after surgery. First line means that's the first therapy that we offer after the diagnosis of a metastatic cancer. So if somebody maybe had cancer 10 years ago and it just came back, the first line of medicine that's what we call first line. And then when that medicine stops working, then we go on to the second line and third line and so on. ADC or antibody drug conjugate, this is a big word or big concept in not just breast cancer, but essentially every chemotherapy drug or every other than the targeted medicines that are a little bit more specific, all of the new drugs that have been approved for breast cancer, but a lot of other cancers too, are these ADCs or antibody drug conjugates. That means that it's a chemotherapy drug conjugated or linked to an antibody. And the antibody kind of hones in on the target, whatever it's designed to target, delivers the compound that the drug directly to the cancer cell, delivers the chemotherapy into the cancer cell, and then the chemo or that drug then kills that cancer cell. And so it allows for targeted delivery of chemotherapy drugs. So it's more like we've turned chemotherapy that used to be carpet bombing into missile strikes. So it allows us to give higher doses of chemotherapy, not with no toxicity, but without excess toxicity. So we wouldn't be able to just hook up that dose of IV chemo to somebody's vein and give that high dose, but we can give a higher dose when it's linked to that antibody. So that's just a quick rundown of what those drugs are. And we're going to talk about a couple of them today. So these are the main breast cancer subtypes. Hormone positive is positive for estrogen and or progesterone receptor. That means those receptors are on the cell surface. The estrogen and progesterone are feeding the cancer. We treat these with hormone therapy, estrogen, anti-estrogen therapy, also chemotherapy. HER2 positive breast cancer is when the cells express a HER2 protein on the cell surface, and that protein basically signals into the cell to keep dividing. So it's a marker of one of the higher risk cancers, but it's also a target. And so it has become one of the most curable and treatable breast cancers because we have that target. Triple negative is all three negative, ER, PR, and HER2 negative. So we can't use the hormone therapy, we can't use the HER2 targeted therapy, and we rely on chemotherapy and immunotherapy in certain cases. There's this other entity called HER2 low breast cancer. This has become more relevant in metastatic disease. So it's the amount of HER2 expression doesn't meet the threshold to be positive, but there's just enough that it can be a target for one of those ADCs or antibody drug conjugates. So you don't need to have every cell positive. You just need a couple of cells positive to get that chemo agent into the vicinity of where the cancer is. And it can still be really effective even on the cancer cells that are HER2 negative. And so that's something that we also pay attention to now. These are the stages of breast cancer. So DCIS or stage 0, this is really a precancer. These cells are confined within the duct and don't have the ability to spread. So when we offer medicine or treatment to patients with DCIS, it's really to get rid of the DCIS that's there, and then the medicines are used to prevent new cancers forming within the breast, but not to prevent spread of the disease because the cells don't have the ability to do that. But stage 1, 2, and 3 breast cancers, those are invasive cancers. Early stage is when it's confined just to the breast. Stage 2 might be a bigger tumor with just a couple of positive lymph nodes, and stage 3 is where there are many positive lymph nodes. Stage 4 is when the cancer has spread beyond the breast and the lymph nodes. So stage 4, this is also called metastatic or advanced. This is when cells from the original cancer in the breast have spread to other parts of the body. So the most common sites are bones, organs like the liver, the lungs, the brain, lymph nodes, and skin. And this happens when circulating tumor cell seeds travel from the breast through the bloodstream or the lymphatic channels, and they can go to new sites in the body and form tumors there. Or they can actually hide out in the bone marrow and just kind of stay dormant for many years and reactivate later, which is why some cancers recur 10 or 20 or even more years later. Metastatic breast cancer poses challenges because every cancer and every patient is unique. Every cancer has multiple mutations that are driving the cancer, some of which we can target and some of which we can't. The cancers are also heterogeneous, meaning certain cells, certain areas of the cancer may be slightly different. So there may be more or less estrogen expression, there may be more or less HER2 expression, or some tumors like in the liver may have certain mutations that other tumors elsewhere don't. And so that poses challenges when we're trying to find 1 or 2 medicines and not a dozen medicines to give at once to target the whole person, the whole body. Drug resistance develops as cancers adapt to tolerate therapies. And so we're constantly in this race with the cancer to try to outsmart it. And so prevention really is the key. And so we have clinical trials aimed at trying to cure more patients, to improve the curative treatments. And then if the cancer does come back, then how can we prolong survival and prevent the cancer from continuing to grow. So now moving on to the meat of the San Antonio meeting. And this was back in December. So we've had a couple months to kind of process things. This is just a summary of the progress that we've made over the last 20 plus years. So we had these starting in the 70s and into the 90s and 2000s is when we had the original hormone therapies that we still use today in early stage breast cancer. So the aromatase inhibitors came out in the 90s and early 2000s. We've had CDK4/6 inhibitors, which are still the first line standard therapy in metastatic breast cancer. They're combined with the hormone therapy. And then you see in the red and the green, I highlighted a couple of targeted pills. So the red boxes are medications that target something called a PIK3CA mutation. The green are oral estrogen blockers, but basically oral estrogen receptor degraders. I do have a slide that I'll kind of talk about how they work a little bit differently than the other hormone therapies that we use. And then the navy boxes are the new antibody drug conjugates. So we've had 3 of them approved in the last 5 to 10 years, all that are active in hormone positive breast cancer. And actually all of them are active as well in hormone negative breast cancer. So this study was called lidERA, and this was probably got the biggest press and the biggest excitement in San Antonio when it was presented. So this was a study of a drug called giredestrant, and that was compared to the standard of care hormone therapy as adjuvant treatment for patients with hormone positive, HER2 negative early breast cancer. So these were patients with early stage curable breast cancer and they were given this as adjuvant or after surgery therapy. So just by way of background, so hormone-positive breast cancer accounts for more than 70% of early breast cancers. Tamoxifen and aromatase inhibitors are really the mainstay of treatment, and the last one of these was approved in the early 2000s. So they're great medicines, but they're, they're a little rusty. We think that there could be improvement because we know that still women who take these medicines can recur. We are now combining CDK4/6 inhibitors like Verzenio and Kisqali with hormone therapy in early stage breast cancer, and that has led to improved outcomes, but has also added more toxicity to patients for 2 to 3 years out of their 5 to 10 years of hormone blockers. And even despite this, up to a quarter of patients can recur within 5 years. And many stop due to side effects. The aromatase inhibitors and tamoxifen have side effects like hot flashes and joint pain and brain fog, just sort of being in menopause. So there's been a lot of interest in newer medicines that maybe don't work on estrogen levels. So they don't reduce estrogen levels the way that the aromatase inhibitors do, but maybe they work on the estrogen receptor. And giredestrant is one of these oral estrogen receptor degraders and estrogen blockers. So here you have in the middle of the screen a cancer cell that has the estrogen receptor on its surface, and estrogen is binding to that receptor, and that's what's driving the cancer to grow. The aromatase inhibitors work by eliminating this estrogen so that there's nothing to stimulate that receptor. But we also know one of the ways that breast cancers can become resistant and start to grow is that this receptor becomes activated even without estrogen binding to it. So it's just like constantly signaling into the cell, even when estrogen isn't binding to it. And so there's this interest in oral selective estrogen receptor degraders that basically degrade or destroy these receptors. So even if there's estrogen around, it doesn't matter because it can't bind to anything and stimulate the cancer to grow. So these typically have fewer of the menopausal type side effects. And in some smaller studies, giredestrant was shown to have better anti-proliferative activity, meaning in the neoadjuvant setting. So that means we do these like window of opportunity studies where somebody's diagnosed with a hormone-positive breast cancer, and then maybe they're waiting for 4 weeks until their surgery date. So we have their initial biopsy, we give them one of these medicines, and then at the time of the surgery, we look and see if the cancer has changed at all. Like, is there less rapid growth? Are there changes in any of the markers? And they did that with this drug and found that it sort of suppressed the cancer growth more effectively than both anastrozole and tamoxifen. So that kind of led the foundation for this study. And these are schemas. So this is where on the left side of the screen, you see all the eligibility criteria. And then on the right side of the screen is how people are randomized. So these were stage 1 to 3 early breast cancer patients, hormone positive, HER2 negative. If patients did not have positive lymph nodes, so if they were lymph node negative, then they had to have something that was a slightly higher risk feature. So a tumor that was more than a centimeter, but also some higher risk feature. So a higher grade or a higher proliferation index, which is the Ki67, or a high oncotype score. Or they could be node positive, and they were pre or postmenopausal, and they were randomized to the standard of care endocrine therapy, which was tamoxifen or the aromatase inhibitors, or the giredestrant for at least 5 years. About 40% were premenopausal. The vast majority were stage 2 and 3. And similarly, most patients had positive lymph nodes, but about 20% had lymph node negative cancer. And about 80% got chemo before they went on to their hormone therapy. And then here I just kind of describe what the risk is. I'm not going to spend too much time on this, but there are different features that characterize high risk versus medium risk. High risk is bigger tumor with maybe skin involvement, more than 3 positive lymph nodes, really high risk biology. And we have just shy of 3 years of follow-up, so that's still pretty early. But I want to just define what this kind of graph looks like, because we're going to see a lot of them. So this is called a Kaplan-Meier curve. And the goal when we're comparing an experimental therapy, in this case, it's the giredestrant, which is the brown or reddish curve, We're comparing that to the standard therapy, which is the gray. The goal is for the curves to separate, and the sooner the better, and the farther they separate, the better. That means that the new therapy, if it's higher, is more effective. So what we're seeing is, what is the chance of being free from progression or free from a recurrence? And so as time goes on, which is the x-axis, we have time, 6, 12, 18 months. And then this is percentage on the y-axis. So 97% of patients who were on giredestrant at a year were free from cancer recurrence, versus 96.9% of patients on the standard of care arm. So not that big a difference, but the curves continue to separate. And by about 3 years, there's an almost 3% difference in that 3% fewer patients had a recurrence if they got the giredestrant versus the standard of care endocrine therapy. So this translated into what they called a 30% reduction in the risk of a new invasive or invasive recurrence compared to the standard therapy. And the benefit was seen regardless of whether you got aromatase inhibitor or tamoxifen. And this was really big, because this is the first improvement or first thing that we've seen in hormone positive early stage breast cancer in about 20 years. There were no serious side effects, no major issues with the giredestrant. Overall, the tolerability was very similar to the standard of care. And that included, somewhat disappointingly, similar rates of joint pains and hot flashes. So they had similar rates of arthralgias, joint pains, and hot flashes. They had more dose interruptions, so more patients sort of paused the medicine, but then restarted it. But notably, they had fewer discontinuations due to musculoskeletal symptoms. And so that, while the incidence of arthralgias, joint pains was not significantly less, patients didn't have to stop their medicine because of it, and that's really important. Bradycardia, or slower heart rate, is a side effect that we've seen in this class of medicines, the oral SERDs, and they didn't see any serious events. It was mostly very minor and not really significant. So this was exciting because it was the first novel hormone therapy to demonstrate a benefit in early breast cancer in over 20 years. It has a favorable safety profile with lower rates of discontinuation. And we do think that the benefit, that those curves are going to continue to separate, because with hormone positive breast cancer, about half the recurrences happen in the first 5 years, and then the other half are spread out over the next 10, 15, 20 plus years. So we really need at least 10 years of follow-up for a study like this to know what the real benefit is going to be. But there are some considerations with this. We can't, unfortunately, just go out there and give this to everybody with early stage breast cancer. For better or worse, in the United States, cost is a factor, and these medicines cost over $20,000 a month. And if we have over 150,000 cases of hormone positive breast cancer every year in the United States, that's a real financial strain on our system. And so we don't know if it's going to be feasible to give this to everybody who might qualify for it. We also have limitations because nobody in this study got the CDK4/6 inhibitors. So those are drugs that we're combining with aromatase inhibitors and sometimes tamoxifen for 2 to 3 years, and that has significantly reduced the risk of recurrence. And we don't know, is that benefit the same if do we add benefit if we use this drug? Can one replace the other? Is it sort of an either or and you get the same amount of benefit? We really don't know. And we also don't know if everybody needs a whole 5 years of the therapy. Maybe they can do 2 to 5 years of standard therapy and then switch for a couple of years. And there are a bunch of studies that are going on looking at kind of how best to incorporate these newer oral medicines, and how we can also combine them with the CDK4/6 inhibitors. And we have a couple of these open at Inova. So we have the Elegant study, we have the Cambria 2 study. These two, I think, have completed enrollment. But the top 2 we have open. So if you are somebody who's on hormone therapy, feel free to ask your doctor about whether you would be eligible for one of these studies.
And you answered the question in the chat, if it would be given in combination with an AI or not. So thank
It's
you.
given instead of, yeah, so this is would be instead of these oral SERDs, but we're still trying to learn if there's a benefit to the CD, like how and whether we even need to add the CDK4/6 inhibitor. Okay, so moving on to hormone positive breast cancer that has progressed on hormone therapy but hasn't gotten chemo yet. So typically in hormone positive breast cancer, we try to exhaust all the hormone medicines that we can. They typically work better, they're better tolerated. We try to delay the time to IV chemo, but inevitably we do have to go to IV chemo. And so this clinical trial was ASCENT-07, which is looking at one of those new antibody drug conjugates, which is sacituzumab govitecan, which is the brand name is called Trodelvy. So patients with hormone positive breast cancer that was no longer responding to hormone therapy were randomized to Trodelvy or to a chemo of their physician's choosing. And there were 3 different ones. Capecitabine is a chemo pill, and paclitaxel and nab-paclitaxel are both IV medicines. And these 3 have been historically sort of used first line or preferred once the hormone medicines stop working. So we were trying to see, is this better than the standard chemo? And remember, we're trying to see a lot of separation of the curves, and we don't really see that with this one. So by the end, the curves are kind of still right on top of each other, which means that this Trodelvy, this antibody drug conjugate, really didn't add much benefit compared to standard chemo. So this was not considered statistically significant. There was a trend towards patients living longer if they got the drug versus if they got the standard of care chemotherapy. But a lot of patients who got the standard of care chemotherapy then went on to get another antibody drug conjugate. And so that makes this a little bit tricky to interpret, but there were some favorable signals that even if you're not staying on that particular drug for longer, does it do something to the biology of the cancer that then maybe makes it more sensitive to future treatments? That would still be important for us to know. So this Trodelvy is as first-line chemo in hormone-positive breast cancer did not demonstrate an improvement in progression. There was an early trend in improvement in overall survival, but the data is still pretty immature. We still need more follow-up. So this drug does have an approval for later lines. So there was another clinical trial looking at including Trodelvy later after a couple lines of chemotherapy, and that was a positive trial that showed a progression-free survival benefit, so a delay in time to cancer growth. So it's still a therapeutic option, but we can reserve it. We can wait to give it until we've used up some of the more effective medicines earlier on. Okay, so moving into HER2 positive breast cancer. This is another graph just showing all of the progress that we've made in the last 20 years. So we've had really in the last 10 years just a boom of lots of different medications approved. We had Kadcyla, we had Enhertu, we have tucatinib, and then we have a bunch of newer combinations that have come out just in the last year, and how we're treating this type of cancer has changed from December of 2024 to June of 2025 to December of 2025 to now. So it's all changing and all really for the better as we have more and better treatment options. So HER2 Climb was the main study that I wanted to talk about. So typically for HER2 positive breast cancer, the standard of care was to give a chemotherapy medicine like Taxol or Taxotere with Herceptin and Perjeta, which are the 2 HER2 targeted medicines. And though that chemo and the Herceptin and Perjeta were given for a couple months until maximum response, and then giving chemo for a long time is tiring, and there's accumulating side effects like neuropathy. And so the practice was to stop the chemo and just keep people on the Herceptin and Perjeta, and then maybe add in some hormone therapy or hormone blockers if they were also ER positive. So this clinical trial was looking at adding after that induction, so after patients received 4 to 8 cycles of that chemo and Herceptin Perjeta combination, the chemo was stopped. They were maintained on the Herceptin and Perjeta. They were allowed to get endocrine therapy, but then in place of the chemo, we added this pill called tucatinib, which is a targeted HER2 blocker. And so it was sort of like an enhanced maintenance strategy to see if maybe we could keep people on that maintenance without having to go back to chemo for a bit longer. About half the patients were hormone positive. About 12% had brain metastases or cancer in the brain, which is really important because tucatinib is known to be active in the brain. It's one of the few drugs that we have in breast cancer that can actually get into the brain. And about 70% of patients had de novo metastatic breast cancer, which means that they didn't have a history of early stage breast cancer before they were diagnosed with metastatic disease, that at the time they were originally diagnosed, they had metastatic disease. So this is the kind of curve that we like to see. This is where they separate early and they separate far. So there was a difference of 8.6 months in that. So tucatinib delayed the time to progression, kept patients on that maintenance therapy for almost 9 months longer than patients who got a placebo. So that was really, so this was really a very positive study. And this was really encouraging. And what they found was that this benefit sort of didn't really matter what other characteristics of your cancer, everybody seemed to benefit. And even patients, whether they were hormone positive or HER2 negative, so there was still a difference in HER2 negative. The difference was over a year. Patients stayed on this medicine for longer. So, think about that. Somebody who's on a maintenance therapy and you're on this combination, you get a year longer before your cancer starts to grow compared to somebody who didn't. So this is a really exciting improvement for us. And then for hormone positive, we saw 7-month benefit. And then for patients who had CNS or central nervous system, there was the numbers of patients here are small, and so the curves don't typically separate because statistically it's just difficult to see differences, but numerically there was a significant improvement in control of the brain metastases. Of course, when we add another medicine, we want to make sure we're not adding too much toxicity, especially if we're expecting people to be on this for years at a time. So the main side effect with tucatinib is diarrhea. Most of it was mild, but 2/3 of patients have it. Nausea is also commonly seen in about 1/3 of patients. And then we see some liver enzyme abnormalities that typically is mild and something that we just kind of keep an eye on as patients are on it. But for the most part, the tucatinib was really well tolerated. So this study concluded that the addition of tucatinib to first-line maintenance therapy with Herceptin and Perjeta demonstrated a statistically significant and clinically meaningful improvement in time to progression in patients with HER2-positive breast cancer. And it had a manageable safety profile, mostly low-grade side effects. So this study is great, but the question is sort of how now do we incorporate it into our treatment plan, because many of you who have dealt with HER2-positive breast cancer or metastatic breast cancer may know that actually that THP, that backbone that we then evolve into a maintenance strategy, is not the standard of care anymore. So things are happening so quickly that a clinical trial that was developed just a couple of years ago is sort of out of date by the time the results come out. So last summer at ASCO, we had the results of one of the clinical trials that showed that a drug called Enhertu, which is a antibody drug conjugate, plus Perjeta is better than that THP chemo. And so we have transitioned a lot of patients or newly diagnosed patients to that regimen instead of the THP. And that clinical trial didn't build in a maintenance phase. Patients who were on Enhertu with Perjeta had over 3 years of disease control on that combination, which is great, but that's chemo. That's not sort of antibodies and hormone therapy, that's chemo. And so more than 3 years of continuous chemo is a lot. We think we can probably de-escalate and sort of back down on some of the chemo, but we don't exactly know. And HER2 also has some risky side effects to it, including some things that something called an interstitial lung disease. And 2 patients in that study actually died from that side effect. And so we take that really seriously. We are in the business of curing people and prolonging life, not shortening their lives because of side effects of the medicines. So there's a lot of question now about, can we use this in HER2 plus Perjeta as kind of an induction, and then de-escalate after a period of time to include medicines like tucatinib. This is where maybe ctDNA testing, so finding signs of cancer in the blood, might help us determine when and if we can de-escalate. And then we also see you can see kind of in these curves here that there's this like tail here where there's a number of people who just stay on the therapy for a really long time. And with HER2, this is unique about HER2 positive breast cancer, where because the drugs are so effective and HER2 is such a really robust target, we think we can actually cure some patients with metastatic disease. Now, this is not the norm. This is very infrequent, but we think it's possible. And so we're looking at that. There's a clinical trial going on. I think it's at Dana-Farber, looking at sort of basically sequencing everything we have under the sun, every chemotherapy, 12 weeks, 18 weeks, 12 weeks a year, and seeing if, like, in patients with limited HER2 positive breast cancer that's newly diagnosed, can we cure them? So we don't know, but we're trying to figure out if there are patients out there who we can do that for. Okay, shifting gears to early stage HER2 positive breast cancer. So these studies actually, there were some updates that were presented at San Antonio, but the primary results were presented at ESMO, which is the European Society of Clinical Oncology, in October last year. So I'm sort of smushing them together and just giving you the update. So these are early stage HER2 positive breast cancer. Destiny Breast 11 was a study looking at untreated, so newly diagnosed HER2 positive breast cancer, hormone positive or hormone negative. They had some kind of high risk feature. So they either had positive lymph nodes, or if they didn't have positive lymph nodes, they had to have a bigger tumor. And they were randomized to one of our standard of care chemo, which is Dosted's adriamycin and Cytoxan, followed by taxane, Herceptin, Perjeta, or 4 cycles of Enhertu, followed by 4 cycles of that taxane, Herceptin, Perjeta. I'm not going to talk about this arm, because they ended up closing that early. So it was the top 2 that were combined, and they were looking to see how many patients achieved a complete response, which means that when they went to surgery, the cancer was dead. The cancer was gone. And what they found was that the treatment, the experimental group with the Herceptin, in HER2 followed by taxane HP, had a 67.3% complete response rate. And that was 11 points higher than the comparator, the standard chemo arm. And it's a little bit higher than what we typically see with standard chemo. I think what was really notable was hormone positive, HER2 positive breast cancer. We don't expect as high a complete response rate, because with the chemo, we're not targeting the hormone driving, the hormone growing part of the cancer. So we see closer to about 50% complete response rates with hormone positive, HER2 positive breast cancer. But we saw almost 62% complete response in hormone positive, and 83% of patients with hormone receptor negative, HER2 positive breast cancer had a complete response. So only 17% still had residual disease. And this is really important, because we know that complete response rate is a sort of a surrogate for risk of recurrence down the road. That if you have a complete response, your risk isn't 0, but it's much lower than if there is cancer that was still alive when you went to surgery. And the updates that we got from San Antonio were mainly about the safety of the drug. They didn't present any new efficacy. So the main concern with Enhertu, of course, is the interstitial lung disease, and nausea is a big side effect with Enhertu. But they found that there were really very low rates of pneumonitis. They only got 4 doses of the drug, and so that's not surprising. There really was no difference in in the risks with this study. And then the other study for HER2 positive early stage breast cancer was incorporating Enhertu after surgery. So right now, most patients with bigger tumors or positive nodes get chemotherapy first. And then if they have a complete response, we just give them HER2 targeted therapies, maybe the Herceptin and Perjeta. But if you have residual disease at the time of your surgery, then we escalate. We give a drug called Kadcyla, which was actually the first antibody drug conjugate that made its appearance here in breast cancer treatment. And that was shown to be very beneficial. It sort of cured a few more patients with that drug. One of the downsides about Kadcyla is that it doesn't get into the brain very well. And so it doesn't change as much the risk of CNS recurrence, but it does reduce the risk of overall relapse of the cancer. And so this study randomized patients to either the Kadcyla, which was the standard of care, or Enhertu. And then they followed them to see how many patients had their cancer return. This was patients who had very high risk disease. So it wasn't just small tumors, negative lymph nodes. They had to have basically inoperable breast cancer diagnosis. So like inflammatory breast cancer or multiple positive lymph nodes. Or if they had operable breast cancer at the time of diagnosis, they had to have positive axillary lymph nodes after neoadjuvant chemotherapy. So this was really selecting for patients with resistant cancer. And again, we see the curve separating. So this is based on HER2 status. There are different ways that we can look at HER2. Overall, the benefit was significant, about a 9 to 10% improvement in recurrence risk with the Enhertu over the Kadcyla. And what they presented in San Antonio was safety. So Enhertu was given for 14 cycles. And that was the idea was that giving more of the drug was going to increase the risk of these worrisome side effects like interstitial lung disease. And we also don't know how giving it with radiation at the same time would that increase the risk of interstitial lung disease. These are patients that we're giving medicine to cure them. So we don't want to be causing more and worse side effects. So they did very diligent surveillance and monitoring with CAT scans. They monitored patients for any signs of interstitial lung disease in patients who got radiation at the same time, so concurrent or after, or waited until they finished the radiation before they started, so sequential. And ultimately, they found that there really was no difference. So there was no difference in the incidence of ILD was about 10%. There were no fatal events, fortunately, and it was not impacted by the timing of radiation. And so summarizing Enhertu in early HER2 positive breast cancer, Enhertu for 4 cycles followed by THP for 4 cycles results in very high PCR rates in both hormone positive and hormone negative breast cancer, but you have to have high risk disease to be eligible. And then Enhertu for 14 cycles was superior to Kadcyla in patients who had residual disease after neoadjuvant chemo. It was safe. Radiation can be given at the same time, which is just nice that you don't have to prolong everything. Actually, so, there were, 2 deaths related to the interstitial lung disease. So an incidence of 0.3%, which is not high, but is too high. You know, like as I said, we don't want to be causing fatal side effects with our medicine. So that's why we have to be really thoughtful about who is best to get these drugs. Neither of these indications are approved yet by the FDA, but are likely to be coming soon, and they are starting to get incorporated into some of our guidelines. What we don't know is who should get Enhertu first before the surgery and who should we reserve it for afterwards. It's not likely that we would give it both before and afterwards. Okay, so moving now on to breast cancer screening and prevention. So breast cancer screening, I don't talk about this often because most of my patients already have had breast cancer, and so sort of they don't meet the criteria for general population screening. But breast cancers are heterogeneous. Some are more aggressive, some others are more indolent or slow growing. But we know 1 in 8 women will develop breast cancer in their lifetime. But on an individual level, the risk varies. So that's based on family history, breast density, hormonal factors. There are a lot of things that play into the risk. And we know that one treatment approach is not standard for all breast cancer. So why do we screen everyone as if they have the same risk? That sort of laid the foundation for this clinical trial called the Wisdom Study. And there have been years and years of controversy and changes in guidelines about how we should be screening, how old people should be when they start, how often, when should we stop. There's 7 different clinical guidelines out there. They're not all the same. And what's interesting is that they're all based on the same data that was generated over 25 years ago. So using mammogram techniques that we have improved on. And what they differ in is how they value different things. So guidelines that suggest more frequent screening and starting at a younger age, value kind of early diagnosis. They don't care as much about, they're not valuing the risk of false positives or biopsies or the anxiety coming with testing. They're just purely about how many cancers can we find. And then others like the USPSTF or US Preventive Services Task Force are placing more emphasis on, like, we want to diagnose the cancers that are going to sort of cause harm to somebody. So stopping at age 74 as opposed to screening somebody into their 80s or 90s where they may not actually die from that cancer. It doesn't really matter maybe that we find a cancer in a 90-year-old. So bottom line is the screening data, the screening guidelines vary. There's no clear-cut guidance. And so the Wisdom trial was looking to see if we could implement a more pragmatic approach. So this was called the Women Informed to Screen Depending on Measures of Risk, and women between 40 and 74 were eligible. And basically they had annual screening, so people could either get annual screening or screening based on their risk. And what they did, I thought, was really clever because women approached them, they advertised about it. You could elect to join the study, but they recognized that some women may not want to get randomized. So, if somebody has let's say their mother had breast cancer, they're maybe not gonna not want to get annual screening. They're not gonna want the chance that maybe they get every other year screening or have to wait 50 years until they're 50 to start screening. So they allowed patients, if they were willing to be randomized, they got randomized to a risk-based screening approach or to annual screening. If they didn't want to get randomized, they could go into this observational cohort where they could choose. And you could say, I want my mammogram every year, or I want risk-based screening. I want it to be more informed. I want the possibility of maybe more screening or less screening. And the risk factors that went into the personalized screening group included things like breast density, which was established at the baseline mammogram, health questionnaire, including family history, age, race, ethnicity, comorbidities, whether they'd had any previous biopsies, and they did some genomic profiling. And patients were then classified based on these risk factors into the lowest risk, and those patients did not start screening until age 50. Average risk had biennial mammograms, and then patients with elevated risks had annual mammograms. They could meet with a breast health specialist. And then the highest risk were patients who had like pathogenic variants, like a BRCA mutation or something like that. Not only did they get annual mammograms, but they also got MRI. And so they were asking questions about whether risk-based screening is just as good at avoiding high-risk cancers. Would it reduce biopsies and false positives compared to yearly screening? Would it encourage women to get prevention if they were high risk? Would women take it up? Would they accept it? And also, does it provide value to our society in terms of overall outcomes and cost? And they looked at the rate of stage 2 or greater breast cancers and the rate of biopsies. So this is the cohort. Actually, I was surprised that 61% agreed to be randomized. And then of the patients that didn't want to be randomized, almost 90% chose the risk-based assessment. And so this is how things were broken down. And what they found was there was no increase in later stage cancer diagnoses with risk-based screening. So there was not a higher risk of cancer or like later cancer. If you went longer time between mammograms, you didn't pay because of it with a bigger tumor. So they didn't find these interval cancers between screening. So the number of cancers didn't differ. The distribution shifted. So they found more cancers in higher risk women than they did in younger risk women and lower risk women. The number of biopsies was similar, but there were more in the highest risk group than the elevated risk and much higher than the average and low risk group. There were fewer mammograms in the risk-based group. That was primarily driven by the lower number of mammograms in the low risk cohort. So they didn't start until 50. So that was 10 years of not getting mammograms that society would have to pay for. And in the average risk group where they only got them every other year. And so even though patients in the highest risk groups had more mammograms and some of them had MRIs, the cost was actually less. So following a risk-based strategy may be more cost-effective from a population health perspective, in the sense that we're doing more screening for those who need it and less screening for those who don't. And this study, the 2.0 version, is ongoing at sites around the country. And then let's see where we are with time. Okay, I'm going to try to rush through this. So BRCA mutations, these are genetic mutations that increase the risk of breast cancer quite a bit. Women who know that they have one may know that they face an increased risk of ovarian cancer and breast cancer, and they're recommended to get their ovaries removed to reduce their risk of cancer. So we induce menopause, surgical menopause, in a lot of these women in their 40s and sometimes even younger. And in breast cancer, we tend to be hesitant about offering hormone therapy because that's sort of the opposite of what we typically do in patients. And also there's evidence that in general population, estrogen and progesterone hormone replacement is associated with a small but increased risk of breast cancer. So we didn't know if it was safe to offer hormone therapy in these women who've never had cancer, but have had their ovaries removed. So they looked at patients with BRCA mutations, had no history of cancer, and had entered menopause. And they found that that menopausal hormone replacement therapy did not increase the risk of breast cancer. And if anything, there was less breast cancer. So in summary, there was no negative effect of hormone replacement on BRCA-associated breast cancer risk. With estrogen alone, there was a lower risk. With estrogen and progesterone, there was at least no increased risk. There are certainly limitations to this study. Any sort of decision about this would need to be made after a really diligent discussion with your doctor. The numbers were small. We need longer follow-up. There may be selective pressure for patients who wanted to enroll on this and actually get hormone therapy. So this is just sort of starting the conversation and providing some reassurance that maybe it is a safe option. And then finally, not to shortchange triple negative breast cancer, these were actually studies that were presented at ESMO that I wanted to include because while we didn't get as much about triple negative breast cancer at San Antonio, we had two huge studies at ESMO just a couple months before that altered how we treat it. And the first was the study called TROPION-Breast02, which is looking at a drug called Datroway, another antibody drug conjugate. And this study was looking at first-line metastatic triple negative breast cancer for patients who were not eligible for immunotherapy. And they randomized patients to either get the Datroway or investigators' choice chemotherapy. And the Datroway was much better. So you can see the curve separate. There was patients stayed on therapy for much longer, and they delayed their time to their next chemo by much longer. So this is a great option. This is a drug that's given IV once every 3 weeks, which is nice. And then similar study looking at a similar population was looking at Trodelvy, again, first-line metastatic triple negative breast cancer, not eligible for immunotherapy. randomized to the Trodelvy or different physician's choice chemotherapy. And again, the Trodelvy beat out the standard of care therapy. So both of these are options. Trodelvy, also a very active drug. This is given 2 weeks on, 1 week off. So day 1 and 8 of a 21-day cycle. They have different side effects. And so that's something just like, how do you decide? That's something that you would decide with your doctor. But these drugs, these antibody drug conjugates are really supplanting sort of our standard chemo in ways that are really exciting. So in summary, progress is being made on every front: early stage, late stage, hormone positive, HER2 positive, triple negative. We have new drugs and lots of stuff in the pipeline. We have made progress in reducing recurrences and prolonging survival in women with stage 4 breast cancer. There's always more work to be done, and clinical trials are always an excellent option. We do have a robust and active clinical trial program. So if you're interested in something like that, then definitely ask your doctor. And with that, I will pause. I think we have some time for questions.
Thank you so much. Yes, if you have a question, you can put it in the chat and we can ask away. Thank you so much.
This is
Okay, first question. What studies are happening now that have been going on for 10 years that you're excited about seeing soon?
the CDK4/6 inhibitor studies started a number of years ago. I think we have like 7 years of follow-up that I've seen. So those are the studies like Monarch E and Natalie that have been going on, that they're the hormone positive early stage cancer studies where we need 10 years of data to see what the full magnitude of benefit is. And we're still getting data from things like RxPonder and TaylorX, which were the studies that looked at using Oncotype, which is that sort of gene test that determines who needs chemo in hormone positive breast cancer. So those are things that are ongoing now that still have a lot to offer.
Thank you. Do you know of any seaweed supplement trials?
Not off the top of my head. Not seaweed in particular, no.
And what do you know about any lobular breast cancer trials?
That's really tough. Lobular breast cancer, it's a common enough cancer, but it's not that as common, so it's harder to enroll enough patients just with lobular cancer to get data, or you need a bigger sample size. We don't have any specific studies for lobular cancer patients, but most of them are hormone positive, so they're eligible for all of the hormone therapy studies that we have, like the oral SERDs, where we're trying to see if they're better than the AIs. MD Anderson has a lot of studies looking for sort of more niche subtypes, but lobular breast cancer mostly ends up getting incorporated into a lot of just the hormone positive breast cancers.
Thanks. For someone who has troponin breast 3 and had a recurrent on it, then was diagnosed with metastatic triple negative breast cancer, would you still suggest Trodelvy or maybe Erbeline?
So that's tough. There's a lot of things that go into the consideration of that, like how long it was between when you got, so that was the Tropion Breast 03 is the early stage Datroway, where we're giving that drug in the curative setting. That might depend on how long it was since you got the drug and when you recurred. The only thing I'll say is that in metastatic breast cancer, we aren't as often giving one ADC right after another, even if they have slightly different chemicals as a component. If they have a similar target or a similar mechanism of action, we usually try kind of a sandwich approach where we do an ADC. If you progress, then you do standard chemo, and then you go to the ADC. So that's kind of the approach in stage 4 that we typically are following.
Great. How much of the breast cancer index do you know about, and what are your thoughts on it?
I think the data is accumulating more for it. It's been around now for a while. Breast cancer index is sort of like an oncotype test for extended hormone therapy, um, where they test the tumor to see if somebody has a high risk of a late recurrence and if taking hormone therapy for more than 5 years would be beneficial. I do think that we have more robust data for it. They have not done like a randomized controlled trial prospective study the way that they did with our exponder or TaylorX for Oncotype, which is the gold standard. What they've mostly done is retrospective. But for patients who are really in the middle and kind of, maybe they have a higher risk cancer, but they're tolerating the drug really poorly, we might send it to get an out. Or if they have a low risk cancer and they're tolerating it great and they don't want to come off of it, we might send it to give reassurance that they don't have to worry about coming off of it.
What do you know about the next generation CDK4 inhibitor treatments trials?
So there are a bunch of there's CDK4, there's CDK2. These are in the same family as the CDK4/6 inhibitors, the oral targeted therapies. The idea is that they hone in on CDK4 or CDK2, and so they may allow us to give higher doses with fewer side effects. So those are making their way through. They're in like phase 2 and phase 3 studies. Nothing that's approved yet, but maybe definitely things that we're keeping an eye on for future benefit.
Thoughts on CDK treatment for node negative high genomic risk?
Depends on other things like tumor size, patient age, other risk features, and what other chemo that you got. If you meet criteria for Natalie, which was for node negative, you had to have a bigger tumor or a grade 3 tumor. We do know they're active drugs and they're downsides, but they're not like life-threatening downsides. And for the most part, like compared to chemo, they're really effective and manageable. So I typically will at least discuss it with patients.
Great. And I think the last question is, what uses do you see emerging for ctDNA testing optimizing treatment?
I think ctDNA is the future. I think we're not there yet, but it's like right there on the horizon. What's really frustrating about ctDNA right now is we know what it means, but we don't know what to do with it. So if you have circulating tumors, so these are blood tests where we can isolate like DNA that the cancer sheds. And if you have it in your bloodstream, it means your risk of recurrence, if you're early stage, is higher. It's not 100%, but it's higher. And if it's negative, it's not 0%, but it's lower. But we don't have studies that say, okay, if you're higher, I'm going to switch you to this medicine, or I'm going to add the CDK4/6 inhibitor now. Or if you're negative, we could say, oh, you can stop your hormone therapy, or you don't need this medicine. We don't know what to do with it yet. I think first where we'll see it being incorporated is in like the metastatic setting with HER2 positive breast cancer, for example, where we want to de-escalate therapy. We want to give patients time off of chemo where we can check the ctDNA. If it's negative, we follow it for a while. And if it stays negative, we can comfortably keep them off of chemo. If it starts to go up, then we might think about giving chemo. But we're actively investigating this. We're doing a lot of it's just really hard because if we have enough data that we really can't make a randomized trial. So if somebody has a positive result, I would not feel comfortable telling them, no, I'm not going to do anything about it. You're going to stay on placebo and that's really how we gather our data. So a lot of this is going to be kind of piecemeal that I think we start to incorporate it more into our practice, potentially without actual data to support it. But I do think that may be how we surveil people. Instead of doing scans, maybe we do the ctDNA. But right now we don't do that because as I said, if you're negative, you don't get to stop your medicine. And if you're positive, I don't know that I need to switch a medicine. I might just say you need to stay on your medicine for now. So that's really, that's a tough spot. Yeah, but it's exciting. It's something that I think is going to revolutionize how we treat breast cancer in the future.
Great. Last question. Are there any exciting phase 3 trials for metastatic triple negative breast cancer with just a TP53 mutation?
There are, I don't have the details. Most of the TP53 mutation trials are not quite phase 3, so they're earlier phase, they're smaller studies. They are run at Inova through our phase 1 program and our molecular tumor board program, because you don't have to have a specific, you don't have to have breast cancer to be eligible for it. So these are sort of all types of cancer. So there are definitely studies that are ongoing. TP53 is a really tough target, but things are being looked at.
Wonderful. Thank you so much for your time. And if you have any questions or need something further, feel free to reach out to me. And we appreciate all of you attending tonight.
Thanks
Thank
so
you.
much, everyone.